Hello, it's Dr. Garrett Pohlman, host of the Prostate Health Podcast. It can be very distressing for men who have continued urinary leakage despite trying conservative measures. Many suffer in silence, not telling anyone about their symptoms. They may be embarrassed and think that this is just going to be their new normal. Well, the good news is that there's hope for these men. Today we have Dr. Brian Flynn with us to discuss 2 available options for these men to obtain relief, so stay with us. So the big question is this: how can men and those who care for them better educate themselves regarding prostate health, the conditions that affect the prostate, and the latest technology in managing these conditions? That is the question, and this podcast will provide the answers. On a weekly basis, we will be chatting with experts, innovators, and leaders in the field of urology, sharing useful information with the general public to improve their lives and increase their overall health. My name is Dr. Garrett Pohlman, and welcome to the Prostate Health Podcast. Prostate Health Podcast is for informational purposes only. Nothing in this podcast should be construed as medical advice. By listening to the podcast, no physician-patient relationship has been formed. For more information and counseling, you must contact your personal physician or urologist with questions about your unique situation. I'm very excited to have joining us today Dr. Brian Flynn. Dr. Flynn is not only a good friend, but also former mentor who I had the opportunity to learn from during my urology residency training at the University of Colorado Anschutz Medical Campus. He is a very talented surgeon, and I truly valued the time spent learning from him. His philosophy is to treat all patients to the best of your ability as you'd want to be treated. He individualizes each patient's treatment based on his or her specific needs and desires. He would always tell the fellows, residents, and students when faced with the clinical dilemma of what to recommend for a patient, just put yourself in their shoes when possible, and the decision should become very clear. Dr. Flynn is a national leader in the use of minimally invasive surgical techniques for the treatment of urinary incontinence. His training included a fellowship in reconstructive urology at Duke University. He has been a faculty member of the University of Colorado School of Medicine since 2002. He has presented at many national and international meetings on urethral stricture disease, urinary incontinence in men and women, ureteral stricture, and robotics. Dr. Flynn, welcome to the Prostate Health Podcast.
Well, thank you very much, Dr. Pohlman. What a tremendous honor to be here with you, and I'm very excited. And I'm really excited to see the things you're doing to advance men's health in the area of prostate cancer. I've known you for almost 15 years now, and we've become great friends, and our families know each other. We have a lot of friends in the prostate cancer world like David Crawford and Paul Maroney that we've learned so much from. And I think this is a special opportunity to be able to speak to patients who have problems with incontinence after prostate cancer therapy. So thanks so much for having me.
Certainly. Thanks again for joining us. So Dr. Flynn, I thought it'd be helpful to start off by talking to our listeners about what is urinary incontinence and how is it related to the treatment of prostate cancer, including radiation and surgery, but also the treatment of benign enlargement of the prostate, or BPH.
Yes. The International Continence Society, which is a group of urologists around the world, came up with a definition for incontinence. Surprisingly, some people aren't familiar with the word. So the word means involuntary loss of urine control. So sometimes we'll substitute words for incontinence like leakage, wetness, accidents, and other words. But I think most people are familiar with the word incontinence, and it's something that many women are familiar with because women will deal with this oftentimes after having children or with aging, after having hysterectomy. I think there's a bias that this is a female-only problem. Certainly not true. Many men can suffer from incontinence, and I think that's what we're here to talk about. Just briefly, there's 2 major types of incontinence. There's stress incontinence, which is related to weakness of the urethra, and that's not related to emotional stress, but that's related to weakness in the urethra. And that usually happens after having prostate cancer surgery or maybe trauma to the sphincter, a transurethral resection of the prostate, and other measures can cause weakness to the urethra. Similarly, a man can have urgency incontinence, also known as overactive bladder. And urgency incontinence is something that more commonly occurs after having some of the other therapies for prostate cancer, for instance, like external beam radiation therapy. So those are the 2 big types of incontinence. There are other less common types, but that's usually the first thing we try to do, Dr. Pohlman, when we meet with patients, is to really characterize the type of incontinence they have, and then that'll allow us to best treat them. And there can be some overlap. They're not exclusive of each other. So a male patient can have both stress incontinence, weakness of the urethra or the sphincter, and then they could have urge incontinence, which is more of a bladder problem.
So thank you for that description. So how common is urinary incontinence after prostate cancer surgery and radiation therapy?
Well, fortunately, it's quite unusual. Only about 4% of men will suffer from what we'd call severe incontinence. That's incontinence that is really disabling, incontinence that often would lead them to have another surgery to fix it because it's so severe. If you use the strictest definition, Garrett, one would consider incontinence if someone was wearing a pad after surgery. And if you look at patients who wear a pad after surgery, that number is somewhere around 4 to 5%. I think that number has come down tremendously since the advent of robotics, and I know you're a big advocate of robotics. And robotics has really been tremendous in really being more precise in doing the prostatectomy. But there's still men that suffer from incontinence afterwards. There's a wide degree of men that maybe are outside of that 4% number that they'll say, I just don't have as good as control as I did before the surgery. Yeah, I don't need to wear a pad, but if I'm shoveling snow, if I'm working in the yard, if I'm lifting weights, if I'm at the gym, I'll have a few drops leak out. And there's quality of life data to suggest that people who have even mild degrees of incontinence can have significant impact on their overall quality of life. If you use that very loose definition, the number might be as high as 20 to 30% if you look at Mark Litwin's data from UCLA.
So now looking at kind of the recovery timetable for urinary control after prostate removal, kind of how does that typically look like for patients?
Well, that's a great question. I think it's important for the surgeon to set expectations because I would say almost every patient has some impairment of their bladder control immediately following the surgery. So you have the surgery, the catheter comes out at 1 to 2 weeks, and immediately afterwards, people can experience some degrees of urinary incontinence. That might be mild or that might be severe. Early interventions that we'd recommend are Kegel exercises, and there's evidence to support even learning this preoperatively, physical therapy and other measures, and I know we'll get into that later. But what you'll see is a gradual return to continence. By 3 months, most men have a return to continence if they're going to have that. So of that 96% of men that are going to be dry eventually, about 3/4 of them are dry by 3 months. 6 months is another important time frame. You're going to get about 80% of the patients who are going to regain their continence will do so by 6 months. And then the other 30-40% who have a return to incontinence will do that by 1 year. There might be some very gradual increases in bladder control from 1 to 2 years, maybe by a percentage point or two, but it's unusual if I see someone who's totally incontinent at, say, 1 year that would all of a sudden regain their continence in the second year. But what we look to see is a gradual improvement. So as long as a man continues to improve, then we'll continue to use non-operative measures. If they hit a plateau, in other words, at month 3, they're still wearing a few pads a day, and at 6 months, they're still wearing a few pads a day, and they've hit that plateau, there's really not a reason to expect them to improve beyond that time point unless there's an intervention. Now, maybe they weren't very diligent in doing their Kegels, maybe no one introduced them to a physical therapist, and maybe that's the intervention. Or perhaps it might even be surgery. If I see a guy at 6 months who's totally incontinent, and that was the expectation, he might have had a salvage prostatectomy. It was a very difficult surgery, a very advanced cancer. And that man, we might offer earlier intervention.
So what options are out there for men who have continued struggles with bothersome urinary leakage despite some of these conservative measures?
So I think we'd like to talk about non-surgical options first and then surgical options. So a lot of the non-surgical options are similar to what the female patient would experience, centering around Kegel exercises. Kegel's named after a urogynecologist, Arnold Kegel, who described pelvic floor exercises. And what that would involve is engaging the pelvic floor, contracting the pelvic floor, similar to if you were interrupting your stream. So people would say, I'm not sure what you're talking about, doctor. Well, we've all had someone walk in on us when we were younger. and be embarrassed and you had to stop urinating immediately. That's the muscle, right? Or more commonly, maybe the entire pelvic floor you want to contract if you're holding in gas and trying to avoid that embarrassment. So you're trying to tighten the pelvic floors, and it's just like lifting weights, right? You're going to do X number of reps, this many sets, this many times a week. And, the more, the better, just like push-ups. So if you can do 25 reps 3 times in the morning, 3 times in the afternoon, and 3 times in the evening, that's a good place to start. Now, sometimes we'll see patients that just can't quite figure that out. And there might be nerve damage even to the pelvic floor. So there's a disconnect between the pelvic floor and the nerves. They have what's called a neuropraxia. Well, that person certainly needs to see a pelvic floor therapist. There's specialists in physical therapy that we call pelvic floor therapists that will specialize in doing pelvic floor PT. Physical therapy, I think, as many people know, can involve a manual adjustment. It can involve using electricity. It can involve using ultrasound. It can involve using weights. So there's a variety of ways of trying to reconnect the pelvic floor with the rest of the body and strengthen the pelvic floor. Now, if those measures aren't working non-surgically, some people will resort to some form of barrier. Many people are familiar with pads. So there's pads that are specifically designed for men. Many people know the word Depends, and Depends makes an undergarment that the patient can wear while they're regaining control. Now, obviously, that can be very uncomfortable. That can be very costly. So some men will prefer to use a device. And devices such as a condom catheter or a penile clamp might be effective temporary measures, or if someone's not a surgical candidate, it might even be a good long-term measure. A condom clamp is exactly what it sounds like. It's a condom that collects urine and then gets connected to a bag. A clamp, similarly, is a clamp that would surround the penis and then squeeze the urethra in order to avoid incontinence. So that's a brief overview on non-surgical options, and I'm happy to speak to the surgical options if you like as well.
Yeah, that'd be great if we could go ahead and get into those as far as some of the surgical options after some of those more non-surgical options have failed.
Well, let's start with going with the time-tested device, the artificial urinary sphincter. That's considered the gold standard treatment for male stress urinary incontinence, sometimes used synonymously with the word post-prostatectomy incontinence. So the artificial, it's not natural, it's a silicone device. Urinary, so it's a device for the urinary tract. Sphincter. So the sphincter is the control mechanism that sometimes patients can lose function of after prostatectomy. Unfortunately, Garrett, there's not a way to surgically repair the sphincter. People have looked at a variety of ways of trying to do that surgically, and we've moved past that. So we've moved more towards replacing the sphincter with something artificial. It's a silicone prosthesis. If you look at implants in surgery, right, there's 3 types of implants. There's polypropylene, there's silicone, there's titanium. Those are the 3 most inert materials that can be used in the human body. And silicone has been used for years for reconstructive surgery in cancer patients, and it's no different in the prostate cancer patient. That silicone prosthesis may be used as a device to prevent incontinence. It can be used for sexual health as well. They're different devices. But the artificial sphincter was invented by a gentleman named Brantley Scott in Houston, Texas at Baylor University in the 70s. And it's had a tremendous track record. Over 4,000 of those devices go in a year. It's never been FDA recalled. There's no class action lawsuits against the device. And it's really been life-changing for many men. I have patients that have told me that if I didn't have this device, I don't know what I would have done for the rest of my life. I'm not sure if I could have lived like this. So it's a surgical implant. The sphincter is put almost in the natural location. There's a device called the pump that would sit in the scrotum, and the patient would operate the pump. And then there's a reservoir that creates the pressure in the system. Pressurizes the system. So it's a 3-piece device. It's a hydraulic device. It's a mechanical device. There's been some changes of the device over the last 50 years to make it easier to operate, to put an antibiotic coating on it to prevent infection. And the cuff had been redesigned many years ago in efforts to lessen the risk of erosion. So That's my quick overview on the artificial sphincter. I can go into more detail if you like.
Yes, that would be great. But first, we're going to take a quick break here, then we'll be right back for more from Dr. Brian Flynn. Thanks again for joining us today on the Prostate Health Podcast. If you're enjoying the show today, make sure you visit my podcast website at www.prostatehealthpodcast.com. There you can find show notes to all our episodes. You can also click on our resources tab, where you can find links to our trusted partners of the podcast, as well as links to books, resources, and products, all of which can help in your journey with either an enlarged prostate or prostate cancer. You can also sign up to receive my free What to Expect guide, which includes checklists of what you need to bring and how to prepare, including what to expect with 3 different scenarios, including your initial urology clinic appointment, a prostate biopsy, or prostate cancer consultation. Sign up for the free guide on the homepage of www.prostatehealthpodcast.com or access this guide directly at www.prostatehealthpodcast.com/clinic. How long, and you kind of alluded to this before in terms of how long you might want to typically wait or hold off before going to some of these surgical approaches.
Well, the artificial sphincter timeline typically is going to be around 12 months. What we'll do when we see a gentleman with incontinence and it's been ongoing for 12 months, oftentimes we'll do a virtual health visit, for instance, on the first visit. As you mentioned, I see patients throughout the region. I see patients from the surrounding 13 states. It's not uncommon that I see someone from Montana and Texas in the same day. And the virtual health is a tremendous opportunity. Many of us are becoming more familiar with that during this recent COVID crisis. And we're really starting to see opportunities to reach out to patients, especially in small towns and underserved communities. And so just getting the patient familiar with the artificial sphincter is a huge step. Unfortunately, there's a lot of misinformation and just a general lack of information for many prostate cancer survivors. Some of the patients will say to me, "You're the first doctor that's ever talked to me about this. I wouldn't have known about this unless I went on the internet." And that's difficult. I think women are more conversational about their health issues, where guys tend to be a little bit more private. Incontinence is an embarrassing condition, right? It makes people feel that they're not themselves. It steals their confidence. And when your confidence is eroded, that leads to social isolation. It leads to depression. People stop doing sporting activities, stop participating in family activities, and it's a downhill spiral. So the artificial sphincter gives someone an opportunity to regain control. And that is often the inflection point. When they regain control, they regain the confidence, they start interacting socially, they return to work, they return to the activities they enjoy. And it's just a tremendous operation, a tremendous gift that I can give to patients to help them regain their continence. And so I have a lot of confidence in the device. The device has about a 90% success rate. 90% of patients would say that they would do the surgery again. 90% of people would recommend it to a friend. A saying that I'm sure you heard me say many times to patients is, I can make 90% of people 90% better. And you might say, what happens to the other 10%? Well, like any surgery, there's going to be risks. And there are risks, and that's that 10%. And maybe they have a lesser outcome. The device can get infected. The device can erode. The device can migrate. The device can malfunction. There could be mechanical failure. And I'm not saying this to discourage patients, but that has led urologists and investigators and medical device companies to look for less complicated solutions. But at least for now, the artificial sphincter is the gold standard. We're very fortunate to have the device. It's very important for patients to find an experienced implanter. I know you were mentioning to me earlier off mic that you have patients travel from out of state to see you for prostatectomy. And this is similar. I think in the artificial sphincter area, there's maybe 100 experts in the country that do more than 50 artificial urinary sphincters a year. If you look at the data from the company that makes the device, Boston Scientific, the average urologist does 1 to 3 artificial sphincters a year. So I think you really want to look for someone who's specialized in doing this surgery, someone who can manage the complications from the surgery, someone who's able to troubleshoot the device, and someone who can offer you an alternative. Let's say we have an older gentleman that maybe they don't have good eye-hand coordination. their hands are weak. Maybe they have a Dupuytren's contracture, or maybe they have a tremor. Perhaps they have dementia. And there's some physical barrier that would not allow them to pump the device. Then we want to offer them a different solution. And there are other solutions beyond the artificial sphincter, but that's usually the starting point, especially for guys with moderate to severe incontinence. The patients who can't operate the artificial sphincter or maybe are not good candidates because of some adverse implantation features, then we can offer them a device called the male sling. We use the word male sling. It sounds unnecessary to use the word male, but when people hear the word sling, they think of a female sling. If you look at slings, they're predominantly done in women, about 200,000 sling operations done in women every year for incontinence. There's about 2,500 sling operations done a year in men, so much less. But if you look at the treatment for stress incontinence in women, it's no different in men. You have the artificial sphincter, you have the sling, and then you have bulking agents. So let's just start with the sling. The sling device, there's a few of them out there. The two that are available in the United States is one called the Advance Sling and now the Advance XP. And that's made by the same company, Boston Scientific, that makes the artificial urinary sphincter. Second company, known as Coloplast, will make what's called the Virtue Sling. So both slings are slightly different, and both have been proven to be effective. You might say, well, who's the right patient for a sling? Generally, we're going to offer that to the patient with mild to moderate incontinence. So let's say a patient says to me, Dr. Flynn, I only leak when I'm playing golf. Do I really need this artificial device in me? It just seems like a big solution for a problem I don't have every day. Well, that's a perfect sling candidate because I know he's bothered. That patient wouldn't have traveled 500 miles to see me if he wasn't bothered. And so for me to tell him, hey, you're fine, don't worry about it. Be glad your cancer's cured. You have other people have worse problems than you. That's not what they want to hear. We're moving into a new age in society, and the whole idea of vitality, in addition to longevity, we want to thrive as we age. We want to continue to golf. We want to continue to go to the gym. We want to continue to make love to our partner. And all those things are so important. And so if you look at the male sling is really a nice device for the patient with mild incontinence. And with some of the new advancements in the sling technology, we can even offer that to patients with moderate incontinence. And they've had good results in people with moderate incontinence, meaning they're wearing as many as 3 to 5 pads a day. As long as they don't have any adverse implantation features, I have found that device to be useful. The last thing to talk about would be bulking agents. The bulking agents have not had the greatest success, so I won't spend too much time on bulking, but that would involve injecting a material to swell the urethra. Just like you see maybe in people using fillers for cosmetic surgery and to give them a more plump, youthful appearance in their face, the idea would be to inject the urethra to get the urethra to swell and to then compress the urethra so they didn't leak. The problem with injectables is that they can migrate, they can reabsorb, there's a pretty high volume necessary, and it's really quite hard to get them in the precise location. Last thing, just real quick, I wanted to mention was the ProAct device. I haven't personally used ProAct, but ProAct has been available in Europe for almost 20 years. It was FDA approved in the United States in the fall of 2019. And it's something that some surgeons around the country are starting to use. I know there's a surgeon in Omaha that's using ProAct. And ProAct is sort of a combination between the artificial sphincter and the sling. I mentioned that it's similar to the sling in that it's a passive device. There's nothing to pump. You don't need any dexterity skills for that. You don't need to have the mental capacity to operate it. But it is an inflatable device similar to the artificial sphincter, which would allow you to inflate the device in small increments to compress the urethra in order to regain continence. So I'm curious about ProAct. I haven't used the device yet, but I've certainly read a lot about it and are becoming more and more familiar. So that's the spectrum of male incontinence surgery in the United States. There's other devices out there that maybe are approved in Europe or Asia that haven't come to the United States yet, but I think we have good non-surgical and surgical options, and I encourage patients to look into these options if they're suffering with post-prostatectomy incontinence or even incontinence after radiation. I don't know how we're doing on time, but I would like to just mention a few things about incontinence after radiation therapy if I can.
Yeah, that'd be great.
So if you look at the spectrum of radiation therapy, brachytherapy is something we're familiar with, where radioactive seeds are placed into the prostate. Those seeds sometimes can lead to obstruction, and that obstruction might cause problems emptying, it might cause dribbling, and that often needs an intervention to clear out, which sometimes can lead to stress incontinence, and in some ways the patient could have the same type of incontinence they did as if they even had a prostatectomy. Radiation therapy generally affects more the bladder than the prostate if there's an adverse complication from that, and that can create a bladder that's overactive, a bladder that might contract inappropriately or cause spasms, might cause pain, can cause necrosis, can cause frequency, urgency, getting up at night. So I want to just take this opportunity to make patients aware of that. So sometimes radiation is offered as an easier solution, but I'd especially caution men that already have lower urinary tract symptoms, are getting up at night, they have a weak stream, they have some urgency, they have frequency. And occasionally patients will come to me for a second opinion, being an expert in voiding dysfunctions, and they'll say, Dr. Flynn, how are these prostate cancer therapies going to affect me? If I have a prostatectomy, what will that look like? If I have radiation, what will that look like? And I'm certainly not going to be able to speak to the cancer outcome. There's other people that have more expertise than I do in those areas, but certainly I will tell them I don't think getting radiation is a good idea for you because your symptoms are just going to get worse. I don't think getting brachytherapy is a good solution for you because you're already demonstrating some obstruction. And then to put a radioactive seed in there, I think you're asking for some problems. And so over the years, there had been this sort of algorithm that maybe younger men would get a prostatectomy and older men would get radiation therapy. But I think we've moved past looking at age, and there's really no cutoff at this point. I think if someone has a 15-year life expectancy, whether they're 60 or whether they're 70, that's the same patient. They have a 15-year life expectancy. And it's our job really to help them make good decisions, well-informed decisions, and have them not only survive their cancer, but thrive afterwards. That's the spot that I think I can help patients in that area of prostate cancer survivorship.
Yeah, and I think I would definitely agree with that too, in terms of, I think we've kind of moved away from just, age in terms of, the older guys get radiation, younger guys get surgery. I think I would totally agree with that. So in summary, this has been very great, Dr. Flynn. I think you've really given our listeners a lot of value. It certainly can be very distressing for these men and their loved ones who are dealing with continued urinary leakage despite some of the conservative measures. Dr. Flynn, you've done an outstanding job today in really discussing with our listeners, really the spectrum of treatment for these men and really giving them hope in improving their quality of life. Dr. Flynn, any parting words of advice for our listeners out there who may be suffering from urinary leakage?
Yes, absolutely. And in closing, I would tell men that haven't had prostate cancer treatments yet, make good decisions, make well-informed decisions. This is a decision you're going to have to live with the rest of your life. Do your homework, go on the internet, talk to your family doctor, talk to friends, talk to other people who've had treatments. There's prostate cancer support groups at every major hospital around the country. Great opportunities to network. When you make your decision, find someone you're comfortable with. That should be someone that you really have a tremendous amount of trust in. And if in most cases you're going to do well, you're never going to need to meet someone like me. But the 5% who don't, there's opportunities out there. And there's treatments and there's people that specialize in these areas. And there's enough experts around the country. I think that there's good opportunity for you to have regain your control of your urinary health and to regain that active lifestyle that you so much deserve. And so I would say that incontinence surgery has really come a long way. It's nothing to be embarrassed about. Don't let it isolate you. Fight through it, overcome it, just like you did with your cancer. This is the next stage. Do it for yourself. Do it for the people around you. They want you to be active. They want to see you at those family events. They want to go out there and do 18 holes with you. They want to see you dance at your granddaughter's wedding. Those are the things that really matter. Those are the things that count, and we can help you with that.
Oh, that's excellent. Dr. Flynn, it's always a pleasure every time I have an opportunity to chat with you. Thank you again for joining us on the Prostate Health Podcast. Really given our listeners a lot of valuable information today. Thank you again.
Thanks, Dr. Pohlman. Have a good afternoon.
Thank you again for listening to the Prostate Health Podcast. We would love to have you join our podcast Facebook group at www.facebook.com/groups/Prostate Health Podcast, or just use the Facebook group search function and search for the Prostate Health Podcast and ask to join. We'll see you at the next episode.